Okay, we're going live. Hi, this is Elliot Fishman, and welcome to Facebook Live. Let's see if I can position myself. I'm at home today, working away. Got caught in the rainstorm, and that's why I kind of have my hair looks disheveled, more disheveled than usual. Though I did get a haircut since last week, so it's a lot shorter than it used to be. So, welcome everybody. Hope everybody's doing well amongst the craziness of COVID. Again, I know everyone's tired. We were speaking with the guys from the lab just a few moments ago, and mentioning that we haven't been or they haven't been in the lab in over 8 months, and I think everyone is a little bit tired. But I think you got to hang in there. There was great news from Pfizer as we predicted, but we didn't predict over 90% success with the Pfizer vaccine. So I think all of us are very excited that it passes all of the other tests and that we can start getting the vaccine. And hopefully by next year, this time, we'll be back to normal. But that's only a hope. But I think people are just not behaving because it's very hard it's very hard to keep locked down. But I think with the numbers going up, it's a little bit scary. I know at Hopkins they're opening some of the floors back up with the air filtration so that they can take COVID patients. I read in the paper like you do. There's so many hospital systems that are being overwhelmed and overrun by patients, literally potentially worse than it was last March and April, which is a bit scary. And the numbers, with COVID, the positivity rate, then the hospitalization rate, and then the death rate all kind of track with each other. So that's a problem. And of course, right now, whether you like Trump or you don't like Trump, the election's over and Trump lost. And so we're having a transition. But for 2 months, it means there's a lame duck in power, and that new president will take effect January 20th. But that's a challenging because, right now it's going to be the most difficult time with COVID because of the fact that, let's be frank, that the Thanksgiving holidays coming up in 2 weeks, and then New Year's and Hanukkah, all these holidays which people get together, and you really can't get together. I think they really need to do a lockdown. I hate to say it, but they're not going to have a choice. If you don't lock down, if you don't close the restaurants, let them be takeout, you just got to act now. Every day you don't act, you're making a terrible mistake. And I think if you're waiting for the White House to basically do something, I don't think it's going to happen because it hasn't happened till now. Now the lame ducks, they probably say screw you all. So again, not being political, I think it's very important that something gets done. Um, and you hate to have a 2 month wait between administrations. So that's kind of somewhat difficult. I mean, look, otherwise you need to have people who can help us, like Peabody and Sherman. I mean, if you had Peabody and Sherman, I'm sure Peabody would figure out a way to get rid of the vaccine. He'd invent some time machine. We go back to 1917, 1918, figure out some solution, then bring the solution back and solve everything. Right now, I think Peabody and Sherman aren't the people who are going to help us. I think we're kind of stuck somewhere between a dinosaur. I won't mention who's a dinosaur. This is one of my favorite dinosaurs, however. This is from Toy Story. And this Fluppalookus, whatever this thing is. Some of you are Harry Potter fans, so you would know who this is. It's a stuffed pink something or other. But I think it's very famous. It's some kind of pet or something. But I think leadership is somewhere between the dinosaurs from millions and billions of years ago and this fantasy world. So we need some reality and not some just doing nothing. So hopefully that'll take effect. And I see Lydiana out in California is laughing. So hey, Lydiana, and hopefully things are well in Palo Alto. This week I'm supposed to speak about oncology, so let me just address that a little bit. We're coming into pancreatic month, pancreatic cancer month, so we'll be talking about pancreas next week, talking about, you can see I got my purple shirt on. This is my Lust Garden shirt. And we're actually presenting to Lust Garden Foundation next week. We've been doing the Lust Garden project almost for 4 years, the deep learning AI for detection of pancreatic cancer. I think we have great results. We're getting better and better, and hopefully they will continue to fund us. So that's a plug for supporting us. So hopefully that'll be the case. Oncology and CT, I think at the end of the day, when you think about CT and you look at the applications we have, the biggest application we have in general is oncology. And the combination of detection of disease, staging of disease, and following up disease is where CT excels And each one of those things becomes very critical. So one of the things in terms of detection of disease, I think one of the challenges in patients with vague abdominal pain, weight loss, vague symptoms is detection of disease. We talk about areas where things are missed. We talk about the pancreas. We talk about the kidney where small tumors are missed or undercalled. But there is that challenge, of course, with the kidneys of overcalling small lesions. So in the kidneys, we balance things out between overcalling and undercalling. Again, the importance of protocols and doing things right. Pancreatic cancer really requires thin section CT, looking for subtle changes in texture, looking for changes in transition of the pancreatic duct, things that we've spoken about. The liver imaging, we look at patients with cirrhosis. Obviously, those are patients we worry more about hepatomas developing in cirrhotic patients. But even in patients without cirrhosis, particularly younger patients, we can see problems. Patients with hepatitis C, for example, increased incidence of hepatoma, need to really look at those patients very, very carefully. We talk about the whole area of oncology in the chest, looking at lung nodules, defining and detecting lung nodules, defining the presence of adenopathy. Is it sarcoidosis or histoplasmosis, or is it a primary carcinoma with mediastinal nodes, or is it a metastasis from renal cell carcinoma or melanoma? So we have developed techniques for being able to try to define specifically tumor types. We look at nodes. If nodes are cystic, then you would think about germ cell tumors. If there's an anterior mediastinal mass and it's cystic, contains fat and calcium, then we say it's teratoma. If it's a large mass, it maintains the thymus shape. I just saw a case the other day. Then it could be thymic hyperplasia. Yes, it could be thymoma, but if it maintains the perfect triangular shape of the thymus and texture is good, then I got to be thinking about thymic hyperplasia, which you can have from a number of different things, but it's a big difference doing a thymectomy versus thymic hyperplasia where you're simply following the patient. So that indeed becomes very, very important in terms of that. We talk about small bowel tumors. We talk about tumors of the GI tract in general, from esophageal cancer to gastric cancer to small bowel cancer to colon cancer. We talk about screening in cancer. Again, whole body screening was something that was done in the past. People talk about it a lot. A challenge looking at small bowel, but we know that detection of colon cancer and virtual colonoscopy is very good for that. Cologuard now is Exact Sciences has Cologuard, which is something you take a stool sample and you could look for the presence of blood. Then you got to find what made the test positive. So things like that, the whole challenge about doing Vert colons, people don't like doing them because reimbursement is terrible. It takes a while. You need special software, which is usually fairly cheap, or you may have it. If you have things like VIA, you have it built in. You have some of the Terra Recon stuff as another company. Most of the people, I think, have it. But you need to know how to use it. You need to feel comfortable. There's so many little bumps and ridges on a Vert colon. You're not really sure if you're looking at 100 polyps or you're looking at simply a lot of diverticuli or simply just retained stool. So it is somewhat challenging in doing Vert colons. And I have been doing them. The person who left, Dr. Ali, and I had done them in the past, so now I've been doing them also. So it's a challenge doing them. There's no doubt the software is better. I can do the flies throughs much easier. The flies throughs work routinely. That's all really good. The challenge is, of course, that I haven't figured out a really good way of looking very quickly at the colon, so it takes me much longer than any other study because you got to look supine, you got to look prone, you got to fly supine, you got to fly prone. I also look at the 2Ds. I look very carefully at the 2Ds and the multiplanars. So people talk about being a 2D reader, a 3D reader. I'm a 2D, 3D reader. I look at everything on everything. So it takes me probably the longest it takes me to look at a scan because you're looking for things that are a centimeter or less. So that becomes a very, very important thing to think about. There's John Biachino, who's in Virag CT today at Hopkins, and John's one of our experts on Vert colon. We'll tell you the key of Vert colon is good colon distension. We use CO2. We use the CO2 pumps from EZM, and those pumps really distend the colon well. You're not going to have a good Vert colon unless the colon is well distended. If the colon is not well distended due to spasm, lack of patient compliance, or whatever reason, the studies are going to be limited in terms of quality, and you're just not going to be able to do a good job. So that indeed becomes very, very important. In oncology, we also speak about the importance of technique in terms of delivering IV contrast material. IV contrast, really, you need faster injections, 3 to 4 cc's minimum. Typically 5 is perfect. With oncology patients, the question about multi-phase versus single phase versus even 3-phase acquisition. Again, people talk about 3-phase in the liver, though we typically do 2-phase. Pancreas, most people agree you need 2-phase, arterial and venous. Kidneys, you need multiple phases. You need non-contrast to make sure you don't have a high-density renal cyst. You need arterial and venous, looking at the arterial and venous mapping, looking at neovascularity, looking at enhancement patterns, giving you lots of information for predicting. And excretory phase imaging becomes very critical because it's easy to miss certain lesions, particularly transitional cell carcinoma in the renal pelvis, in the ureter or bladder. You don't have really good delayed enhancement and excretion of contrast. Now, it is true I could see a lot of TCCs, particularly in the bladder, with a little bit of enhancement, but not always. And it's easy to miss. We also make sure we give the patients 1,000 cc's of water before the study. That helps the bladder get well distended. Again, you're not going to see much in the bladder. If you're looking at the bladder and the bladder's collapsed, then what do you say? You say bladder undistended, can't rule out mass. So I hate the word can't rule out because someone sends you a study to rule something in, rule something out. If you can't rule something out, maybe it's too small, maybe this, that, and the other, but technical reasons, it's somewhat more difficult. We speak about protocols for doing these patients, oncology patients, and you're kind of stuck. In many ways, I like the water because it helps me out looking at a lot of the vasculature, and I like vascular mapping, and surely you need it for things like pancreas and kidney. But for some of the other things, not giving oral contrast is problematic because Perry Pickard wrote a good article showing it that often you miss small tumor implants or even larger tumor implants on bowel or in the mesentery because you assume it's just nodes. You don't really think about what's going on. With positive contrast, excuse me, with everything filled in, you're not going to make that problem. It's just not going to be as difficult as it would be without. So that's my pitch on oncology patients to really do good protocols. If you ask me about AI, I think AI is going to have a big impact on oncology on several reasons. One is, like we do with Felix, early detection of tumors, whether it's pancreas or kidney. I think you're also going to be able to predict the pathology of tumors based on their radiomic signature, which can be helpful. Will you get rid of biopsies? Someday maybe, but not for a very, very long time. So Ralph Rubin and his guys in pathology have no worries from us in that regard. I think, however, we are going to see, and you are beginning to see, more impact of AI in oncology is in predicting response to therapy. Will the patients, what's the best therapy for this specific patient? The idea of personalized medicine, where things are designed not for the random person or the mainstream person, but for all people, where maybe 75% of patients get cocktail A, but 10% gets B, and another 15% gets C. So a lot more of this personalized medicine, I think, is what you're seeing. And oncology is really the #1 place for personalized medicine, because if you think about it, we do so many things like multidisciplinary conferences where everyone kind of is looking at the same patient from surgery and oncology and from radiation therapy and radiology and pathology, and you're coming up with very specific answers in how you manage the patient. I think that one of the things that you need to do in your hospital, in your practice, is really figure out consensus statements. What needs to be recommended? How do we do specific studies? I think those become very important. And you need to work with your referring clinicians so that your recommendations match what they do. The worst thing to do is say, I recommend a biopsy of the adrenal, and then you find out people don't want adrenal biopsies because Jason Prescott at Hopkins makes the point that you seed things if it's malignant, and you make more complications than it solves. If you think it's a benign lesion, I need to take it out, I'm taking it out. I don't need a biopsy. If it's a malignant lesion, I don't need a biopsy. The only time maybe you want a biopsy if someone is not a candidate for surgery, they have something in the adrenal, they have a lung cancer or some other thing, and you're worrying about Mets, which will upstage the patient, then of course you can do it. But again, it's not the run-of-the-mill way of doing things. I do make the point also in oncology patients, there's a great push at times to push people through. We have been looking at ways of pushing people through, optimizing flow while maintaining quality. Again, really working carefully with the nurses, with the entry people who are going to see the patient early. Patients drink early when they're getting the IV put in. They could be drinking positive or neutral contrast. So you don't waste time. You kind of kill two birds with one stone. You do both things simultaneously. I think what needs to be done for many of the things we do is really line up how we do things, think about them, and see where in your workflow the things don't work as well as you would like them to. I think that becomes very important. And in oncology, it's especially important. Other things with oncology, of course, if you're doing abdomen, always look at the lungs that are available, which may be between 10 and 20% of the lung. Look for PEs. It's not uncommon for incidental PEs on abdominal CT that are commonly missed, particularly on thicker sections. We always do thin sections for the lower lung fields if that's the area we have, and carry that through the liver. But you need to be able to take a look at that. It becomes very important, and I've seen many misses in that region. So you want to really be careful. So let's see. I'm at this. Hey, B Mudge. B Mudge is in Owings Mills. Bill B. I'm in Owings Mills too. Last time B was in where was B? B was in Ocean City. So B's back in the homeland, probably locked up and getting takeout or something. Yeah, I did get a haircut last week. Angel cut my hair. Angel's been cutting my hair for 30 years. I did get a haircut. So now it's a mess today, but it's a lot shorter. I mean, it was like, it's this time of year in Baltimore, all the leaves are falling. So I got my hair cut outside. So my hair kind of got mixed in with the leaves, but I think some of the animals weren't too pleased with that. I was kind of ruining their leaves. And then we got a whole bunch of other people. Almo Perez from Malaga, Spain. It sounds like a good wine place. And B has given me the umbrella. Yes, it's raining hard out, but I do try to take a walk on days that I'm home, which is like the weekend and maybe one day during the week. And Jim Zinreich and Ava Zinreich make me go for a walk, so I get my 10,000 steps. I think I'm told after 3 o'clock today the weather's going to clear up, and it's been raining cats and dogs here. So, but we've had really good weather. This past weekend was in the 70s on the East Coast. That's really good because it's Thanksgiving time. Normally it's in the 50s, so it's 20 degrees above where it should be. But nobody was complaining, except, of course, more people were outside, which meant more people were in contact with other people. More people were not wearing masks because when it's warm, they don't want to wear a mask. 4-year-olds don't have a problem with a mask. 24-year-olds and 44-year-olds and 64-year-olds somehow have a problem with masks. I don't know what their problem is, but they don't seem to like to wear it. Anyway, anyone have any questions? So that's kind of a little bit of an overview on oncology. And we've been doing a bunch of new lectures, which are oncology, that are coming out, including the use of IV contrast in an oncology patient. We've been doing a lot of work with things like extramedullary hematopoiesis, doing a lot of new lectures. I'm going to record a few more today. And hopefully, you're enjoying CTisus as well as Facebook. Hopefully, you've been able to see many of the new contents we put in. We've realigned things, made things easier to use. There's a lot of really good things in there, and we're continuing to grow. And there's Karen from Sweden. So we got everything covered from Owings Mills to Sweden and everything in between. So if no one has any questions, I'll stop there. If you have any questions after, you can ask them and we'll try to get back to you. If not, forever hold your peace. And with that, I wish you all a great day, and hopefully the news will get better. Catch you later.